All right, let's dive into a really important clinical practice review from the New England Journal of Medicine. It tackles a problem we see all the time: how to properly manage insomnia. We're going to break down the evidence right here.
So the paper kicks things off with a scenario that, let's be honest, is incredibly common. We have a patient with chronic insomnia, she's worried about getting hooked on meds, and she just feels like things are spiraling. This is the exact clinical challenge we're going to unpack.
Okay, first things first. Before we can even talk about treatment, we have to appreciate just how big and how serious this problem really is.
Look, this isn't just about a few bad nights of sleep. The data shows that chronic insomnia affects a full 10% of adults. And for half of those people, it's not something that just goes away. It becomes a persistent, long-term condition. The ripple effects are serious, too, with increased risks for major depression, hypertension, and even Alzheimer's disease.
So, knowing all that, where do we start? What does the evidence actually point to as the most effective first-line treatment?
Well, the answer, and this is backed up by pretty much every major clinical guideline, is not a pill. It's cognitive behavioral therapy for insomnia, or CBT-I. This is a very structured therapy that's designed to get at the root of the problem, the thoughts and behaviors that are actually keeping the person awake.
So what does CBT-I actually involve? It's really a multi-pronged attack. You have sleep restriction, which is all about syncing up the time you spend in bed with the time you're actually asleep. Then there's stimulus control, which is about retraining your brain to see the bed as a place for sleep and only sleep. And a huge piece is cognitive therapy, which helps patients reframe all those anxious, unhelpful thoughts that race through their minds at night.
Okay, but let's talk numbers. How well does this stuff actually work? When you measure its impact on insomnia severity, the main thing patients complain about, you get this number.
An effect size of 0.98. In clinical research, that is huge. It shows a powerful, significant impact. And it's not just a quick fix. We're talking a 60 to 70% clinical response rate. But here's the kicker: 40 to 45% of patients are still in remission a full year later. This data makes it crystal clear. CBT-I is the benchmark. It's the standard for effective, long-lasting treatment.
Okay, so we've established CBT-I as our gold standard. Now let's bring in the medications and see how they really stack up against that benchmark.
We'll start with the classic sleep medications, the ones most people think of, the benzodiazepine receptor agonists, or BZRAs. You might know them as Z drugs.
Now, these drugs absolutely work for getting people to sleep. They have moderate to large effect sizes. However, and this is a big however, the risk profile is a major concern. In the short term, you worry about next-day grogginess. But long-term, the data points to real physiologic dependence, a higher risk of falls, and even a potential link to an increased risk of dementia.
All right, let's look at a newer class of medication that has a totally different mechanism of action: the dual orexin receptor antagonists, or DORAs.
So here's the key trade-off you need to understand. The DORAs, they have smaller, less potent effect sizes than the BZRAs, but their big advantage is a much better safety profile. We're talking a lower risk of cognitive and motor impairment and a much lower potential for abuse or dependence.
Okay, what about something we see all the time in clinical practice, using sedating antidepressants for insomnia? Well, the evidence here shows a pretty big gap between what's commonly done and what's actually approved.
This is fascinating because it really highlights a disconnect. The only drug in this class that's actually FDA approved for insomnia is low-dose doxepin, and it has a pretty small effect size. Meanwhile, trazodone is used off-label all the time, but the data on its efficacy is inconsistent, especially for helping people fall asleep, and it comes with its own set of risks like cardiac issues.
And finally, let's cover what our patients are often trying on their own before they even come to see us: over-the-counter options.
The evidence here is pretty cut and dry. For melatonin, the effect size is just tiny, 0.13. It barely moves the needle for falling asleep and has no real effect on staying asleep. And for sedating antihistamines like diphenhydramine, there's just not enough data to support using them. And we know they come with those concerning long-term anticholinergic side effects that can increase dementia risk.
So we have all these different options on the table. What does this all mean for our long-term strategy? And is it ever a good idea to combine therapy with medication?
Now, this is a really critical point. If you look at the treatment trajectory, in the first month, sure, the combination of CBT-I plus a medication gives you the fastest results.
But look what happens over the long haul. That early advantage completely disappears. It turns out that CBT-I alone is the superior long-term strategy, giving the most sustained benefits and, importantly, the lowest rates of relapse.
Okay, let's boil all of this down into a clear, practical management strategy you can actually use.
The evidence really points to a three-part approach. Number 1, initiate CBT-I. That's your foundation. Number 2, use medications judiciously. Reserve them for short-term use, maybe during an acute flare-up caused by stress. And number 3, this is crucial. For any patient already on long-term hypnotics, you need a clear, systematic plan to deprescribe.
So if you only take one thing away from this, let it be this. CBT-I is the definitive, evidence-backed first-line treatment. The data is more robust for it than for any other intervention out there, period. That huge sustained effect size says it all.
The second key takeaway is about the role of medication. It's a tool, not a foundation. It should be seen as a supportive measure, not the primary long-term solution. And when you do need to use a medication, the evidence suggests newer agents like the DORAs or low-dose doxapen have a much better safety profile than the older BZRAs.
And all of this leaves us with one final critical question. The evidence is overwhelming. CBT-I is the gold standard. So the real challenge isn't figuring out what to do, it's figuring out how to do it. What are the real-world barriers, cost, access to therapists, lack of training, that are preventing this proven first-line treatment from being the first thing we offer to every single patient who needs it?